This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Okay, so thank you so much for the invitation here today. It's really lovely to be here. And I was thinking what to call it. It's a little bit facetious because I was like, what am I going to call it to the cognitive neuroscience, Cog Neuro Hub? So I say, why should cognitive neuroscientists even care about delirium? So of course, we're all biased in our own little niche fields. I obviously think this is the most important thing. And I hope at the end of this, you care about delirium a little bit more than you otherwise, than you did this morning. So also, I would love questions through the talk. I really don't want to just be talking for this whole time. So please just shout out if you've got a question, if something doesn't make sense or you want to know more about something. But does anyone really know what delirium is apart from Daniel? Yeah? So it is I feel it's quite understudied, under-acknowledged and undervalued. So I thought I'd just start with what is delirium? And the first thing is that it is actually in the DSM. So it is a psychiatric diagnosis, and if you go to the chapter on neurocognitive disorders, you'll find 3 neurocognitive disorders. The first is dementia, which everyone knows about. The second is mild cognitive impairment, which people are pretty familiar with. And the third is delirium. So it's in the DSM, it's in the ICD, it's technically a neurocognitive disorder. So it's precipitated by an acute insult. So someone can be completely fine at 10 a.m, you can be having a conversation with them, they can be telling you what's happening in the news, and then an insult happens. And that could be a surgery, a procedure, a systemic infection, something that sort of is completely decompensating the brain. And then that person will be experiencing delirium. So it has an acute presentation, and it's typically fluctuating. So people will be sort of going in and out of symptoms, and that can happen over hours or days, rarely weeks and months, but it's possible. So this acute insult is typically a surgery or an infection. It's acute in presentation, typically fluctuating, and according to the criteria, there has to be a primary disturbance in attention, an arousal, and then an additional disturbance in cognition that could be any cognitive domain, so language, memory, any executive function. It can't be better explained by a pre-existing disorder or coma, and it varies in some key dimensions. So the severity, so it can be mild or moderate or severe. The duration, it could be hours, it could be days, rarely weeks and months. And particularly interesting to my talk is that it has subtypes. And these subtypes are hypoactive, so people generally be difficult to rouse. So even at 2 a.m, if you're sort of trying to pat your grandma on the shoulder and wake them up, it's just very difficult to increase arousal and engage with people. It'd be very difficult to maintain a conversation. People might say very short sentences. All the typical presentations of hypoactivity. Then we have hyperactive delirium, which is agitation, restlessness, lots of motor activity, and sometimes delusions and hallucinations. So they might think that snakes are coming out of the wall, the nurse is actually an undercover police officer, all sorts of interesting reports. And then you have mixed delirium, so people can fluctuate between the hypoactive and the hyperactive symptoms. So you have these 3 main types of delirium that are under this diagnosis. Please jump in if anything's unclear. So it's actually super common. So it's actually found in about 15 to 30% of older adults in hospital. Now it can occur in the community, it's less than 1%. So we don't generally go out in the community and measure delirium, but it's super common in hospital settings. There was a good paper on World Delirium Day where they got thousands of people across UK hospitals. They found a prevalence rate of 15%. I'm going to talk particularly about two surgery types, one with the interesting acronym CABG, or coronary artery bypass grafting, and one TAVI, so transcatheter aortic valve implantation, or TAVI. It doesn't really matter what these are acute insults. Don't worry about the actual mechanisms of the surgery, but just know they're both cardiac procedures. We've done a lot of meta-analyses. I don't know about you guys in Melbourne, but during COVID, we published about, 6 times the meta-analyses that we plan to publish. So I'm going to lean a lot on those in this talk, but we have published meta-analyses on both CABG and TAVI, and those rates were about 25%. So about 1 in 4 older adults undergoing these procedures will experience delirium. Delirium's super serious, so it's not to be brushed off, although a lot of people feel hopeless about the diagnosis and then not a lot is done. But if you are to imagine any bad outcome in an older adult, it's associated with delirium. So increased mortality, institutionalisation, frailty, hospital stay length, distress, cognitive impairment, about 9-fold the risk of dementia within the year, and it costs about $9 billion. So every poor outcome in older people is seen at increasing rates after experiencing delirium. A very common conclusion, and one that was drawn hopefully up until a few years ago, is that people are arguing that it's the effect of hospitalisation. It's actually not the effect of delirium. So yes, you're seeing increased dementia and death and institutionalisation, but that's because these older people were in hospital. And then Sarah Richardson in the UK did a super cool study where she embedded herself within an existing population-based study. So she was in the Cognitive Function and Ageing Study, or CFAS, and she's a geriatrician in Newcastle. So she got nearly 2,000 people from the Newcastle site, and these people had been tracked for years, and she knew their baseline cognition and depression and all sorts of demographic factors. And then for 1 year, an incredible feat for a PhD, she went and assessed all of these people for delirium if they were admitted to hospital. So at any day over that year, she was in there assessing any of these people for delirium. So she ascertained prospectively over 12 months who had gone into hospital, and of those people who had developed delirium. Some people went into hospital once, some people went in 12 times. These are all people over 65 years of age living in Newcastle, 2,000 of them. And so essentially she had 3 groups. She had those that never went into hospital, that was about 60% of people. And then she had people who went into hospital who never developed delirium. And then she had people who went into hospital and did develop delirium. And co-varying for every single thing you could think would be related, she found that it was delirium and not hospitalisation that was associated with dementia, death and cognitive decline. So if someone developed delirium over that 12-month period, they had a 9 times increased risk of developing dementia at 12 months. So these are really serious cognitive outcomes of delirium. She also looked at continuous measures on the mini mental state examination. As much as we hate the MMSE, it's pretty much omnipresent in ageing research. And I'll come back to the MMSE, but just to let you know that it's out of 30 points. So people experienced, on average, decreased 2 points if they had experienced delirium. So hopefully this paper convinces you that it is delirium, not hospitalisation. So why, as a bunch of cognitive neuroscientists, should you really care about delirium? Well, delirium is really bad for the brain. We know, through cognition, dementia, if you experience delirium, you can have a really poor outcome. Interestingly though, delirium is partly preventable, and I'll come back to this, but we can prevent about 30 to 40% of delirium through behavioural changes. so non-pharmacological changes. So there's a window of opportunity. This isn't like completely destiny in these older adults of experiencing delirium, and I think that's a super exciting window or opportunity. It's predominantly a functional brain disorder, and I'm drawing that conclusion because it's acute and fluctuating. So that's primarily going to be the manifestation of functional changes to the brain, and I think we all care about those. Current clinical prediction tools in the field of delirium perform really poorly, and I think there's a bit of an opportunity for cognitive neuroscientists to make an impact on that. So if you have a heart condition and you want to know a prognosis, you get an ECG. Why can't you get an EEG to understand your risk of developing delirium? And we also know very little about the neurobiology of delirium. So empirically, very few studies have been done. If you just put like EEG and delirium into PubMed, you probably get about 800 studies, of which about 100 might be vaguely relevant. If you put dementia in, you'll get 6,000. I mean, just the effort that's been put into dementia compared to delirium is just enormous. And for those who are interested in theory, we really lack good testable theories with falsifiable hypotheses. So there are theories of delirium. I'll put one picture, which is one theory of delirium. And like, where do you start with a testable hypothesis, like falsifiable hypothesis there? Like, there is just, everything is going on all together, all at once. So how do we actually come up with theories that we could actually test? Now, I hope that sounds super exciting. Why isn't everyone doing delirium and cognitive neuroscience research? It's actually really super hard, and it's really messy. And I just thought I'd tell you, like, it doesn't occur in a vacuum, and I feel sometimes when you're doing delirium research, it feels like you're juggling a million things and perhaps not doing any of them so well, because there is so much to consider in an older adult who is unwell, whether that's a systemic infection or whether they're unwell and they need a surgery or procedure. So there's a lot going on, and we always have to think about these predisposing factors, like what's putting people at risk of developing delirium, and then we think about the precipitating factors. So what is actually going on, like that actual procedure, that actual surgery, what's going on there? Is it the surgery length? Is it the anaesthetic? There's so much you have to measure, and it does get really tricky, and it really, I feel like that has probably hampered a lot of research efforts. Yes?
On that point, I was going to ask you a question. So you've talked about delirium very much as an age-related issue. To what extent is the massiness also, so drug-induced psychosis is an example. You see a lot in younger people. And it would have a lot of overlapping features to delirium.
Yeah.
Various points in the DSM was called drug-induced delirium. So is that part of the picture here, or how do you consider those things? Are they related or
Yeah. Good question, yeah. And probably an important point that you can get delirium at any point in the life. You could get it as a baby, a toddler, a child. Right now, whatever age you are, you can get it. It's just way more common in older age. And essentially, if the brain is decompensating, essentially anyone could get it if they're pushed far enough. I don't know much about the younger people. We did do a systematic review of EEG measures in delirium, and there were a few papers, and they pretty much showed the opposite findings to older adults. So instead of like reduced connectivity, there was higher connectivity, and things like, instead of EEG slowing, there was sort of higher frequencies shown. So the influence of development is definitely profound if we can draw sort of longitudinal conclusions from those data. There is a whole area of alcohol withdrawal delirium, and that is a section in the DSM, and it has, but I don't study it, so I don't know it well. But essentially it's sharing the same features. As to whether it's sharing the same biology, I'm not sure. Okay, so now I thought I'd get into actually some pathophysiology. So what do we even know about what's happening in the brain? And at the time of delirium, but also what's making people at risk and what's sort of long-term outcome of delirium. And I sort of have started, front to back. So I started getting interested in delirium through my postdoc in the UK with Carol Brain and her current then PhD student, a geriatrician, Dan Davis, who is very passionate about delirium. And I got to work with him on these studies, and I think they're super great studies of his. So essentially these are population-based studies where people are tracked over time in terms of their cognition and dementia, and their brain pathology or neuropathologies are captured at death and essentially then linked back to their clinical features at life. So the first study was looking at a Finnish population-based study. About 500 people, 250 of them donated their brains at death. So just looking at the clinical features, if someone had delirium over that time, they were about 9 times the risk of developing dementia. So this sort of 8 to 9 times keeps on popping up again and again. And delirium was a strong risk factor for incident dementia, but it wasn't driven by pathologies that we associate with late life dementia. So, does that come up? Don't know if there's a point. Anyway, if you look at the blue, which is the middle dots, and then versus the red, these are all neurobiological or biological risk factors for dementia. So bright stage, which is tau, amyloid, then we've got infarct, severe neuronal loss, alpha-synuclein and ApoE4 allele, which is a high risk factor, genetic risk factor for dementia. All of these markers are associated with having clinical dementia if you've never had delirium. But if you've had delirium, none of those markers were associated with having clinical dementia. So it's almost like the delirium to dementia trajectory isn't really driven by these dementia-related pathologies that we're measuring. We followed that up with keeping the Finnish study, but adding to UK studies. So now with 1,000 brains, and instead of looking at individual neuropathologies, dividing up to sort of, did they have a low loading of neuropathology or a high loading? So you had low and high, and then did they have delirium or not have delirium? And essentially, delirium was associated with the same rate of cognitive decline as having a high neuropathology load. So both of these, delirium seems super important to developing cognitive decline and dementia, but not really necessarily or not predominantly through all the neuropathologies we think are associated with late life dementia. So what's going on? We have started to look at EEG in the context of delirium. We did do a systematic review and found that delirium, and most studies were at the time of delirium. So not before or long-term outcomes, but essentially high EEG slowing, so more delta and theta, lower alpha, along with reduced functional connectivity and complexity. They were all associated, all of these features were associated with having delirium, so at the time of having delirium. There have been other studies, so Rob Sanders, who recently moved, in the last few years to Sydney, he's done a lot of work in the context of anaesthetics and EEG and delirium, and he has done, reported similar things, and also there's a big European group, the BioCog Consortium at the moment, who are also reporting similar findings. They've reported recently that structural disconnectivity is associated with delirium, and then that leads to white matter change over 12 months. So there is work. It's not like super great. If you were to present it at ACNS, a lot of it might not be loved. A lot of it is based on BIS monitoring. I'm not quite sure if anyone's come across bispectral monitoring, but it's essentially a single EEG lead that's put on people during surgery that has proprietary algorithms, and you just get spat out a number. So you have no idea what's happening inside the box in terms of processing, and it's all proprietary, so you don't actually know what the data is. So there's real need for higher quality research, and also there's pretty much nothing on vulnerability and also long-term outcomes. So there's a lot still to explore. Also, there was no study that we could find that looked at delirium subtypes, and generally no one accounts for these predisposing and precipitating factors. And, you know, some people could argue that's not necessarily a bad thing, but maybe you're just measuring the effect of age, not delirium per se, and you really want to be able to split those apart. If you're ever to get like a good clinical risk prediction tool, you want to be able to measure, not all 90-year-olds are going to develop delirium, so how can we take all those precipitating factors and predisposing factors out of the equation and look at delirium risk directly? So we started to ask ourselves, I suppose moving backwards, well, can we actually measure with EEG delirium vulnerability? And part of me, I don't know, you might have similar experiences, sometimes like comments just like a bit annoy you, and I kept on coming up to this comment with geriatricians when I kept on asking about subtypes, and I feel as cognitive neuroscientists who work in psychiatry, you're always interested in symptoms, because unless you're a dualist, a system means, like a subtype or a different like cluster of symptoms means there's something going on differently in the brain. And I'd sort of keep coming up with these similar, like, and everyone's like, what about subtypes? What's happening there? Like, and they're like, look, it's a flip of a coin whether someone develops hypoactive, hyperactive, or mixed delirium. There's nothing in it, Hannah. Or just don't be so obsessed by subtypes. So, but I was like, no, but I mean, all the other psychiatric diagnoses have different things going on in the brain if you look at the subtype level. So surely there's something in there. Also, if we're looking at vulnerability, we can actually now start to get away from precipitant factors and just looking at predisposing factors, which makes it probably the cleanest you'll ever get in the area of delirium. And also we know that there's lots of other psychiatric diagnoses with vulnerability states. That's another thing, talking to people working with older people, that whole vulnerability at risk state wasn't something they thought about a lot. But I think that we were quite happy to think that there's probably a brain state that makes people more vulnerable to develop delirium versus not. We also knew, because we did another meta-analysis, that some people are more at risk to develop one subtype or the other. So we know that some people are differentially at risk to develop hypoactive or hyperactive or mixed. So is this like feeding through in our brain activity? That evidence came from Erica's PhD, and she did a big meta-analysis looking at any clinical factor, like any factor she could ever look at that discriminated between the three groups. And they were all predisposing factors, so were measured before someone developed delirium. And obviously, it's completely dependent on what the previous studies actually measured. But there are clinical factors that seem to predispose people to develop hyperactive, hypoactive, or mixed delirium. So there are clinical factors. Are there EEG measures? And this was Monique's PhD, but Marta and Daniel have been involved in this project. So she recorded EEG from 32 channels in people's homes around 2 weeks before surgery. And this was all Tabby and Cabbage back to the cardiac procedures. So she would drive out with another research assistant to someone's home and record EEG and a whole lot of demographic factors, anywhere between 1 and 3 weeks, but generally about 2 weeks before their surgery, collecting resting data and a passive auditory oddball. Then they underwent their Tabby or Cabbage. Of course, elective procedures are pretty much the only experimental method, quasi-experimental, a natural experiment, you might say, to actually have that acute insult to then measure if they do or don't develop delirium. So then we measured delirium in hospital every single day they were there. TAVI patients often actually get put back home at day 2. We even went out to their homes to see if they developed delirium in home. So essentially we had these people, we had their EEG completely blind to if they did or didn't develop delirium, and we had if they developed delirium and the subtype they developed if they did. So I'll say on the next slide as well, but this study was conducted over the pandemic. So we only managed to record data from 58 people. Would have loved for more, but I know you guys were more severely affected in Melbourne, and I can't complain, but yes, there were large swathes of time we weren't allowed into hospitals. But essentially this study did aim to identify preoperative resting state EEG and auditory or ERP markers of incident delirium and its subtypes in older adults undergoing elective cardiac procedures. And the data were collected about 2 weeks before delirium was measured. You can see that these are real people in a central public hospital in Adelaide. It's interesting, for one paper we got a pushback that our people had lower SES than average and sort of a bit more impaired than you would otherwise see. It's like the opposite bias. But they are real people undergoing cardiac procedures in the main public hospital in Adelaide, the Royal Adelaide Hospital. So they're quite old, about 75 years on average. There's more men than women because that's what cardiac procedures generally see. And there's a massive range of ACE scores. So there's actually some quite impaired people in this sample. The ACE is like the MMSE, a bit more comprehensive, and it's out of 100. So this paper is currently under revision and it has a big warning of really not well powered. You can dust with salt or heap with salt as you please. But I feel like there are some exciting findings in there. But essentially we found no differences between those who did and didn't develop delirium in baseline EEG measures, so before they underwent their surgery. But we did find differences in the EEG and ERP markers if we looked at subtype, and luckily our protocol was focused on subtype, so it was these analyses were planned to be done, and I think it's a super exciting different pattern of results to say this is a subtype dependent pattern of results. So thanks to Daniel for working with Monique to come up with these pretty plots. These are the resting EEG data, as most people are doing, FOOFing now, or SPECTRAM as it's now known, but we've got the eyes open and eyes closed. Here is delirium versus no delirium, nothing happening. Here we have eyes open, eyes closed, no delirium versus the 3 delirium subtypes. And here plotted are the offsets and exponents. And we did find significant differences, so increased offsets and exponents in the hyperactive group. So those who went on to develop hyperactive delirium. Now, using that salt as you please, we've also in the paper reported effects that weren't significant but had moderate to large effects, and there were non-significant moderate to large effects of the exponents. So the offsets were significant and exponents weren't, but all had moderate to large effect sizes. The incident mixed delirium, no significant effects here, but moderate to large effects for higher exponents than the no delirium group. So each delirium group is being compared to no delirium only here. And for hypoactive, lower, although not significant, but moderate to large, moderate effects here for the exponents being lower or smaller than the no delirium group. We also had the auditory oddball ERPs. So again, same. We're looking at delirium versus no delirium, found no differences. Then we looked at no delirium compared to each of the subtypes. And here, it really was all about mixed delirium for the most part, which is interesting because it's often the forgotten delirium subtype. It's a bit, it's even messier than just pure hypoactive and hyperactive, but I think these analyses are really suggesting it's really an interesting entity in itself. So there were significantly higher P3 amplitudes to standard and deviants and higher P1 amplitudes. Again, non-significant moderate to large effects for higher P1 standard amplitudes and N1 deviant amplitudes. For incident hyperactive delirium, not significant, but higher P1s and N1s and MMNs. And I didn't actually report the hyperactive. There wasn't much interesting going on there. So from Monique's PhD, now a paper, can we actually capture brain vulnerability to delirium? Well, maybe yes, but we're of course underpowered and we're really hoping for no global pandemics anytime soon. I think it is super exciting because we reported these EEG data before we even knew they had delirium, let alone one subtype or another. And these findings were really subtype based. So it wasn't about delirium versus no delirium. So a flip of the coin, I would say it is not. So current theories describe delirium predominantly as a disorder of functional brain disintegration. Our data with that dusting of salt suggests lots of related processes. So disturbances in arousal networks, EI balance, impaired sensory gating, increased firing, neuronal firing, these are all possibilities. There's also like a tantalizing match between the essentially the neurobiology and the symptoms. Like we're seeing increased hyperarousal in the hyperactive group and reduced arousal in the hypoactive group. And that is pretty tantalizing, but really we need a big sample. So luckily we got an NHMRC Ideas grant last year that will start this year with Marta and Daniel, and so it's tentatively called the DIVULGE 2 study. So essentially this grant is going to be able to do what we did with Monique's PhD at a grand scale. So we've got a whole big team of scientists and clinicians. We've got 4 hospital sites spanning from North Adelaide to South Adelaide. We're aiming to collect 350 older adults undergoing both cardiac and non-cardiac surgeries. And we're hopefully doing a sort of an embedded longitudinal study to start to get some data around what's happening during delirium and long-term outcomes. We've got more channels so we can do more exciting analyses. So yes, this is super exciting, and thank you to anyone who might have been a reviewer on that grant. But it's really exciting to actually do this in a big cohort and look at some super exciting things. So stay tuned. The last thing I thought I'd talk about is intervening, because this is another thing we've been dabbling with and looking to expand. So I said that there is a potential to prevent delirium. So about 30 to 40% of delirium cases can be prevented. And that's really what at the surface looks really simplistic behavioural factors. So getting people mobile and active, cognitively and socially stimulated, getting good sleep, hydrated, good food. Now it sounds really simple, so why isn't this done all the time given we've known this for over 20 years? So Sharon and I, in a newspaper published in New England Journal of Medicine in '99, showed what's been shown again and again and again. And that's because delirium doesn't always sort of manifest after a hospitalisation. It often presents on admission, so prevention is dead. You're only looking at treatment. It's logistically tricky and costly. So all of these behavioural interventions are actually way more expensive to implement than, say, a pharmacological intervention, and just not logistically possible all the time, because people are primarily looking after the reason people are hospitalised, not a side effect of delirium. So this should be done more in our hospitals, but it's certainly not going to be the only thing that we should offer, because people will inevitably get delirium. We have done, again during the global pandemic, a intervention study in CABG patients, and we did cognitive training in the weeks before surgery and then 3 months after surgery, and reported no change in any outcome. And that was a really good lesson in how to implement this training and intervention in older, frail adults. But we've started to think more and more about rehabilitation as the focus, and more multidisciplinary and tailored and modular. So we've also got a grant at the moment from the South Australian Hospital Research Foundation to co-produce a delirium rehabilitation program, and Courtney and Jonas are working on this. So at the moment we're developing this intervention, looking for funding to then do an implementation efficacy trial. But our main aim is then to actually embed EEG and to look at how brain, functional brain measures are changing if we actually can change the trajectory of decline after delirium. So that is what we're working towards. So where to? Delirium is a common and distressing condition. I hope I've stressed that. In our lab, we're really committed to doing sort of embedded cognitive neuroscience in hospitals and clinical services. Like, we really would love to develop prediction tools, rehabilitation strategies, and understand the neurophysiology and how we can change that neurophysiology. We're really focused on subtypes. We think there's a lot more to that, and it's been undebated previously. And we're looking to test this multidisciplinary intervention and track brain outcomes as well. So to end, why should cognitive neuroscientists care? It's common, serious and costly, underappreciated, especially in the context of cognitive aging and dementia. You can't really do, you can do it, but you're going to just ignore it. If you're doing a study on dementia or cognitive decline, you are seeing the effects of delirium. We know that 40% of older adults are hospitalised, and we know that 30% of them will develop delirium. So you are measuring the effects of delirium, whether you are measuring delirium, that's up to your study design, but it's sort of an elephant in the room when it comes to cognitive decline and dementia. It's really understudied, there is so much to do empirically and theoretically, and really interesting symptom profiles and clusters. Is it incredible that this one diagnosis has these hypoactive symptoms, but at the other end of the spectrum, these hallucinations and delusions and very interesting symptoms. So yeah, get in touch if you're ever interested in collaborating. That's the group in Adelaide on a sunnier day. Thank you very much. Questions? Yes?
Thank you so much. That was really
Thanks for having me.
so good. I have two related questions. One is how much overlap could it be between delirium and, say, psychosis more generally? Because you mentioned hallucinations and delusions are typical presentations, and they are primary symptoms of schizophrenia as well. So I wonder whether there is difficulty in disentangling these two conditions apart. And the other question, which I should know, is how do you diagnose delirium? You went through the the critical features, but is there a structured interview? Is there a maybe you mentioned this and I can skip the list. So yeah, those are all my two questions.
Very good questions. I think with the overlap, I would love to do an aging cohort of people with a psychiatric diagnosis history. And I think that our current funding bodies are really bad at funding longitudinal studies, because it would need to be longitudinal to capture people, and I think the ultimate study would also be seeing people going in and out of hospital multiple times to see if they develop similar symptoms of delirium, or, how much changes. I think that who knows what the overlap is between psychosis and delirium in terms of the underlying, brain mechanisms. That is a completely open question. I think that it would be great to try and get older adults with a psychiatric history and see them through hospitalisation, measured delirium. I think that you'd need to be really good at differentiating, like say, the schizophrenia from the delirium, but there is no reason why someone with schizophrenia shouldn't have a diagnosis of delirium. So, but yes, that is a completely open question. We know very little, and I think it would be a really super interesting question to pursue. In terms of, there are so many clinical tools. So there's screening tools, there's diagnostic tools, there's also, of course, clinical opinions. So like every other psychiatric disorder, there are dozens of different tools that are suited to different situations. So there's like ICU ones, there's ward ones, and they all have their pros and cons, like every other psychiatric diagnostic method. But yes, they're established, and there's probably bordering on, I don't know, like less than, like, I think there was a review, there's probably a sort of, I don't know, 80 to 100 different methods. Yes?
You were talking about the predictors, what predicts the different subtypes of
Yeah.
delirium, but do they have any differences, consequences, and the outcomes?
Yes, they do.
Are they, I don't think you remember, did I miss it?
No, I didn't even cover it. So yes, if you have, it's hard. Like, I don't think there is a meta-analysis on this. So, different studies show different things. But I think for the most part, if you have hypoactive delirium, you have worse outcomes in terms of institutionalisation, mortality and dementia. Probably another outcome, though, is the trauma of having it, and that's more common in the hyperactive. If you are having delusions and hallucinations, and these will be remembered, and you're sort of traumatised by that experience, that's probably more common in the hyperactive subtype. Yeah.
Hey, I had a similar question about the subtypes. I was just curious about, because you mentioned that delirium is generally an acute state that people are presenting, and I assume you measure them in that state. I was just curious with the subtypes, whether people kind of fluctuate between subtypes over different delirium states, and
Yeah.
I wasn't sure with the mixed subtype, is that someone presents both symptoms from both subtypes, or do they fluctuate?
Yeah, good questions. If they are hyperactive or hypoactive, they'll fluctuate between those symptoms and no symptoms or no delirium over hours or days. Not everyone fluctuates in that way, but for the most part, people do. And those with mixed delirium will display those hyperactive and hypoactive symptoms at different times. Because I suppose there's the core, between the subtypes, there's that core impairment in attention, arousal, and another cognitive function. So that's, I suppose, maintained over the whole time. But in terms of if you have mixed delirium, maybe at 11 it's hypoactive symptoms, and then at 2 p.m. it's hyperactive symptoms. So it's sort of that transition between those two groupings. Yeah.
Thank you very much for the talk. Actually, my question may be not related to you today's topic, but I just want to know, because you say like delirium can be occur at any age.
Yeah.
So I'm just curious, what would be the risk factor for children? Like, how can you diagnose and how can you prevent these, or if children may, we can prevent some disease, some sort of in children.
Yeah. Look, I put the main caveat of that, children is not my thing. I have children, but I don't research childhood delirium. I would say that, because delirium is so much more prevalent in older adults, the research and the clinical work has been biased that way as well. That's not to say there are large interest groups in paediatric delirium, but I'd say they probably implement the same types of prevention. So, as far as I know, telling parents around sleep and nutrition and hydration and keeping children socially and cognitively active, even if they're, in a bed in hospital, is probably important in terms of preventing delirium.
It's also fever.
Yeah, well, any systemic infection, yeah. Yeah, Olivia.
Two questions. One simple, I just noticed like the gender differences in the risk factors of the different subtypes. And so one question was all those other factors.
Yeah.
Did you do the EEG split in the non-delirium people to check that there wasn't?
Yeah, I think that gender might be another thing I'd love to pursue more in the future. And this is where it gets to the juggling balls thing. And we didn't split it up because our numbers were like disastrously low already when we're splitting up to the subtypes. But older women live longer, they have less education, and they've generally had a less engaging occupation. So women, you have the risk factor of being older, they're older than men, so they're more likely to develop delirium anyway. They have less cognitive reserve because of their life experience and the situation, the status of women at the time. So I think whether it's a women thing, which it might well be, or as with science, it's usually a bit of everything, but it might be a bit of sex differences. It also just might be a bit of differences with their life history coming to that point of having delirium, because we know that just like cognitive reserve and dementia, if you have more education and more, engaged occupation, you're at lower risk of delirium. Well.
Thanks for the talk, Hannah. It was great. And I had lots of questions. The one I was going to ask here was, what was your thinking around the choice of 2 weeks prior to surgery? And to your point about sometimes people are possibly with delirium, is there, what does the evidence suggest might be the sweet spot there?
Yes. In terms of people arriving to hospital with delirium, it's usually more of the infection, systemic infections, or sometimes, they did have a procedure in hospital, they went home and then things didn't go right and they presented to hospital again. For us, we like a little bit of quasi-experimentalism, so it was good to just know that they were going to have a surgery and that was going to be the acute insult. So as a consequence, delirium research has been quite biased to surgery because it does provide that opportunity to have a baseline. So, we don't really know if that's generalises. I think that's an open question as well. As to the 2 weeks, that was a real discussion with clinicians. It was a real, now we have some great clinical relationships, but we were just starting to establish these, and I think it was decided that there was enough time for people to sort of then not have the pressure of it being close to the surgery, and for us to feel like we were getting valuable data. As for the sweet spot in terms of brain activity, who knows? But I would say that we turned up at people's houses and they thought they were going to, for most of the conversation, I think I'm going to die in 2 weeks. So these are older, frail people who are undergoing, Keage, that's an open heart surgery. It's a pretty major surgery. Very major, huge surgery. And so, and they've got so many appointments in that 2 week period. They're in the hospital doing the pre-op visit. They have to see different people. They need to see their family because they are scared and anxious about, what's happening in 2 weeks. So it actually wasn't a hugely empirical lead-based time. It was more a time that we thought, the clinicians thought that would be acceptable. As to what we'll do in the future, I'm not quite sure. People have got a lot on their plate.
No, just as you were talking,
Yeah.